Dr. Kahan, you have 5 minutes.
Thank you for giving me the opportunity to speak on the opiate crisis. My talk will focus on opiate agonist treatment, or OAT, and safer supply. Opiate agonist medications, including methadone, buprenorphine, and slow-release oral morphine, are usually dispensed under supervision at the pharmacy. Take-home doses are given when the patient reduces high-risk opiate use. All 4 medications are long-acting potent opiates. At the right dose, they relieve withdrawal symptoms and cravings for a full 24 hours. Research has shown that opiate agonist therapy reduces opiate use, injection-related infections, and overdose death, even among people who use fentanyl. Unfortunately, only a minority of fentanyl users are engaged in opiate agonist treatment, and retention rates may be declining. There are several strategies to improve access to OAT and to improve treatment retention rates. Opiate agonist treatment should be available on-site and immediately to patients in the emergency department or hospital, withdrawal management services, and rapid access clinics. In order to accomplish this, emergency departments and hospitals should have on-site addiction services. Opiate agonist treatment should be available to people regardless of where they live. This can be accomplished through virtual care. The Alberta Virtual Opiate Dependency Program is highly successful and a model for the rest of the country. There is a need to pilot and evaluate innovative medication protocols that provide quick and substantial relief of withdrawal symptoms and cravings. For example, methadone combined with slow-release oral morphine. Community clinics that provide opiate agonist treatment should have on-site access to wraparound services, that is primary care, mental health services, and case management. And now I'd like to discuss briefly safer supply programs. In these programs, hydromorphone tablets are dispensed to high-risk opiate users, sometimes in combination with opiate agonist treatment. Several studies have found that these programs are associated with a reduced risk of overdose. However, safer supply has not been directly compared to opiate agonist treatment with respect to overdose rates or rates of injection-related infections. The programs typically dispense hydromorphone tablets as a take-home medication. Patients are sometimes prescribed 30 to 40 tablets per day to take home. Safer supply patients can sell these tablets, which is called diversion, or they can inject them. Diversion of take-home hydromorphone tablets appears to be common based on clinicians' reports from patients and families, media reports, and qualitative studies. Diversion has been a major factor in other drug epidemics, including the Oxycontin epidemic of the 90s and early 2000s. Reports indicate that hydromorphone tablets are being sold not just to people who use fentanyl, but to youth and to people on opiate agonist therapy. Hydromorphone tablets are very inexpensive, and even high school children can afford them. Criminal gangs are clearly involved, and these tablets are now being sold in remote communities. Researchers in Canada have not looked at the harms of diversion of take-home hydromorphone tablets, but earlier research have found that youth who used diverted prescription opiate tablets were at higher risk for subsequently injecting the tablets and higher risk for switching to heroin. I personally have had patients who switch from diverted hydromorphone tablets to fentanyl. Fentanyl is also inexpensive, and it produces a more sustained euphoria and withdrawal relief than the tablets. Unsupervised injection of hydromorphone tablets is also a serious problem. Evidence indicates that injection of prescription opiates increases the risk of life-threatening bacterial infections such as endocarditis. There are several practical and evidence-based strategies that safer supply programs can undertake to improve the safety of their programs for patients and the public. One strategy is to dispense hydromorphone tablets under supervision. Research has shown that supervised dispensing of opiate agonist medications markedly reduces the harms of diversion and unsupervised injection while having minimal impact on treatment retention rates. Another strategy is to combine hydromorphone with optimal doses of opiate agonist medications. Opiate agonist medications are long-acting and thus more effective at relieving withdrawal symptoms than hydromorphone tablets. OAT will also reduce the need to prescribe large numbers of hydromorphone tablets.
Dr. Kahan.
I'm sorry, your time is up, Dr. Kahan. I'm sorry, your time is up. If you could just finish your sentence, but your time is up.
Sorry. Oh, okay. I'm basically done. Thank you very much.
Ms. Goodrich, thank you very much, Chair. Thank you to our witnesses.
It's a really important subject, as you guys all know, and I've got a few questions. Just to, at the end of this, we're hopefully going to have a report, and in the report we'll have a series of recommendations. And I truly think it's important to make sure that we're looking at action as we're moving forward through this. And so, I guess I will start out. Dr. Kahan, you talked about the importance of OAT therapies in addiction treatment, and I was just wondering if you could expand a little bit on Alberta's model when it comes to the virtual opioid dependency program, how that works and how you think that could possibly be spread across the country.
Yes, I think the Alberta model has been highly successful. I mean, they are starting thousands of people in the same day on opiate agonist treatment, and that includes people in remote communities, people who have attended emergency departments or hospitals. And this is the way to do it. Canada is such a dispersed, geographically distant communities. We need to get OAT to where people are, in their communities, in the hospital, in the emergency departments. And virtual care is an efficient way to do it. They have 24/7 services, I understand it. It's not just virtual care. They have connections to prescribers, nurse practitioners, and physicians, as well as to pharmacies. So I think it's a very good model to make sure that people in remote communities and people who have lack of transportation, people who are in hospitals and emergency departments have access to care.
Thank you for that. I know I did a tour recently of the Calgary Arrest Processing Center with the Calgary City Police, and they actually had the ability to offer people that were recently arrested the access into the VOPD program right from the Arrest Processing Center, and were telling me some of the successes they had, which is a really cool build out.
To Dr. Kitchen. Dr. Kitchen, you have the floor for 5 minutes, please.
Thank you, Mr. Chair, and thank you all for being here. And sorry, unfortunately, you had to do with the protocol of the House here and interruptions, et cetera, but I appreciate you all. In your opening presentations, you all made some significant points that I think that we all wanted to hear. And, Dr. Goyer, you talked about something that I agree with 100%, which is diagnosis first, and then you lead to the treatment. And I appreciate that comment because I think it needs to resonate a lot more with people. Ultimately, I think what we're looking here is how do we need to be recovery oriented, and I think that's being missed. That recovery orientation needs to be one of the biggest focuses that we have. And I come from Saskatchewan. I come from a very rural area, and I mean I have with me basically the OAT standards from the College of Pharmacy Professionals, as well as basically a map of what's going on in Saskatchewan right now in where doctors are even trained to do it. And that's a huge aspect of how do we make certain that we have that access to these rural areas, because the focus apparently to me that I see is the big cities and not rural Canada, and that's important. Dr. Kahan, you sort of talked a little bit about rural areas, and I'm wondering if you could comment on basically when we look at best practices, things that we need to look at. Is it valuable to be putting in safe supply, or more so for an OAT program? I'm wondering if you could have some comments on that.
I think that it's unfortunate that there's been this binary discussion, safe supply or no safe supply. I don't think that that's what the focus should be. I think the focus should be on ensuring that safe supply is actually safe for individual patients and the public. And this idea of prescribing large numbers of take-home tablets is actually harming people. It's leading to unnecessary and deadly bacterial infections, and it's leading to diversion, which increases use of hydromorphone and then ultimately fentanyl among youth and among people on OAT and other problems. This can be practically and feasibly made safer by having hydromorphone tablets. The issue is not hydromorphone versus methadone. The issue is take-home versus not take-home. And if you allow take-home and people who are clearly involved in the drug trade, you're going to have diversion and it's going to harm people. So have supervised hydromorphone, supervised methadone, supervised injection opiate agonist therapy. That's what's needed. In terms of rural communities, it really is a very bad situation. At least in Ontario, some of the OAT providers are these large corporate chains that do not provide high quality care. Even physicians that want to do good care have limited access to case management and mental health resources. And some rural communities have no OAT at all. Some pharmacies neglect or refuse to dispense OAT. That is a problem, and I think it's very unfortunate that SUAP has put all their resources into safer supply, yes, and other initiatives while downplaying opiate agonist treatment. And I think that needs to be changed. There needs to be a balanced approach.
Thank you. I appreciate that. And I do appreciate how you, in your presentation, you've been very clear and educative in your presentation as well, because you've talked in language that Canadians can listen to, as opposed to the researchers. And that's what I think people that are watching this meeting want to hear. They want to hear it in their language, not in researchers or technology. And while I may understand it, there are others who don't. And so I appreciate those comments.